Good morning, good afternoon, good evening. Welcome to VLU Grand Rounds. My name is Lowell Kabnick and I'll be the host. Today we're talking about thermal imaging and venous disease early results. Dale Maharaj will be the main speaker, followed by David Wright and Dr. Manal Marwa, who will be our discussants. The floor is yours, Dale.
Hi, good day, everyone. I am going to share my presentation and get straight into it. Are you guys seeing anything at all?
Not yet.
There we go. That should be it.
There we go. And if you bring it up to presentation mode, that'd be great.
Okay, so here we go. Good day, ladies and gentlemen. Let's get straight into the topic. We're going to talk about the use of thermal imaging in venous disease. I have no disclosures. So, as you know, the US remains the gold standard of venous investigation, but it does require expensive equipment, specialized training to perform and interpret. It is operator dependent. It can take approximately 45 to 60 contact minutes with the patient and can sometimes lead to discomfort in squeezing or compressing the patient's leg, leading to incomplete venous assessment and reflux mapping. This can lead to missed pathology, especially in early disease. So what is the solution? Maybe thermal imaging, a test that is quick, takes 2 minutes, is sensitive and specific. It's a non-contact study, so there's no patient discomfort, and there is no exposure to radiation. It requires inexpensive equipment with no need for highly trained technicians. So just putting things in some perspective, this is the electromagnetic spectrum, and just between visible light and radio waves is this infrared area here, which is what we're really going to talk today about. And that represents a wavelength of 760 nanometers to 1 millimeter. And of course, it is these cameras, the thermal cameras, which pick up this infrared radiation. And they've come a long way because infrared mapping or cameras or thermal cameras have been around since the 60s. And now we have new cameras that can store images on the cloud. They can be used clinically for comparison before and after procedures, and one can use even AI to help detect subtle patterns of disease. So what is venous tomography? What exactly are we looking at? So tomography is a non-invasive technique using thermal radiation to measure and record temperature patterns and distribution in the body. The skin's surface temperature varies with underlying tissue heat, in this case, venous blood flow. The core temperature is about 7 degrees higher than exposed skin temperature. Refluxing blood from the deep system, 37 degrees Celsius, flows into the superficial system and heats the overlying skin. A thermal camera focuses the heat pattern to create an image or heat map, which can be color-coded for temperature. And these diagrams that I stole from a paper from Dr. Sofa, who's done, and Dr. Wright, who've done some significant work on thermal imaging. Here you can see what exactly happens. The refluxing blood from the deep core into the superficial system heats the skin around the perivenous area. And that is exactly what the thermal camera picks up. So again, just to put things in perspective, this is a simple, straightforward case. As you could see here, hopefully you all could see my pointer. Here we can see a standard photograph. And on the right-hand side, you will see the thermal image that corresponds to it. And this, of course, suggests this lit up area suggests that there is great saphenous vein or one of its tributaries incompetence. And we were speaking a little bit about the heating of skin. It was thought at one point in time that the heat or the thermal signature produced by venous disease or superficial varicose veins was due to perivenous inflammation. But we've shown that this is not true. Here's a patient standing, and as you can see, the thermal images are quite pronounced. But when the patient lies, those thermal images disappear. So it has very little, if anything at all, to do with inflammation, which should not disappear instantaneously. And hence, this is a good example of, again, why patients who are being investigated, be it either thermal imaging or DUS, must be standing. Now let's look at patients with a high BMI. I'm sure ultrasonographers will agree that patients with high BMIs and patients who have colored skin, for example, Fitzpatrick 4 to 6 groups, it tends to be very difficult to see varicose veins in these patients. But here we could see the unseen using thermal imaging, and you can see distinct patterns of venous disease in this patient. Now, how many of you are inundated with referrals for these little lateral bumps that GPs can mistake for venous disease? Of course, clinically, this condition can be relatively easily excluded, but thermal imaging confirms that. For example, here you see no heat pattern in the area where this little bump is, implying that this is a fascial hernia rather than a varicose vein. Now let's look at thermal imaging and wound care. So here's a classic patient with a venous ulcer. How many of you, what would you all do when faced with this patient? Of course, you know, your instinct is to start compression therapy, but would you start compression therapy without confirming using a DUS? Now, in many countries, including Trinidad and Tobago, and I know in the States, the waiting time for a DUS can be quite long. Thermal imaging can be used as a triage to very quickly get an idea or sense of what is happening with the circulation of the patient. For example, in this case here, you can see a distinct pattern of linear bright lighting, implying that there is some sort of great saphenous or great saphenous vein tributary reflux contributing to this this venous ulcer. And here's an interesting patient that I did some months ago. So I did his ultrasound and he had classic great saphenous vein incompetence. He initially presented with some discomfort in his legs. So we did the endovenous ablation and sclerotherapy after, but his symptoms on the lateral aspect of his leg, including pain and heaviness, never really disappeared. And when we did thermal imaging, here we found classic lateral perforator, which at least I tend to miss because I don't routinely go interrogating the lateral part of the thigh in any great detail routinely. So this patient had a significant varicosity on the lateral part of his leg. He underwent foam sclerotherapy and his symptoms disappeared. Now, what about thermal imaging and monitoring treatment efficacy? Here we have a patient who underwent great saphenous vein ablation and sclerotherapy. He would have had a hybrid combination, sclero and ablation, followed by maybe 2 sessions of sclerotherapy. And this is his before. As you could see, the bright, it's red actually, so this is quite hot, for want of a better term. And 3 weeks later, look at the significant change. So when this patient saw this, he was actually quite amazed. And what we've noticed is that patients understand these images. They look real to them. And it is not difficult to explain the whole pathology of venous disease. And this, of course, increases compliance, but we'll get to that in a sec. Oh, well, we already did. So here I'm explaining to a patient using a thermal camera where they can see themselves and they can see images of their legs. And this has increased the patient compliance, patient education, increases patient compliance. So very quickly, limitations of thermography include that it cannot detect deeper CVI, such as, in some cases, the proximal GSV and SSV. There are physiologically hot areas, example, the popliteal fossa, anterior tibial border, and over the hamstring tendons, that can obscure or be misinterpreted as CVI. CVI also is obscured by inflammatory conditions of the skin, even recent tattoos. It cannot detect deep reflux and deep venous pathology. The findings of CVI is a prelude to DUS. And so far, all studies are small and primarily retrospective. In conclusion, tomography is readily available with an FDA-approved device. It is inexpensive, rapid, requires limited training and interpretation. In venous leg ulcers, it provides easy triad, separating those with SVI from those without, implying quite a good negative predictive predictive factor of approximately 90%. It works well in patients with high BMI and colored skin. It improves patients' understanding and compliance. This is very critical, not a replacement for DUS, but an adjunct to improving completeness and efficiency in diagnostic assessment of patients with venous disease. Thank you.
Thank you, Dale. That was clear and very easily understood. I'm now going to our discussants. The first one I'll ask is Dr. Marwa Salih. She has an experience with this as well. And then I'll go to David Wright.
Very interesting talk and really clear slides, really good to hear. Thank you for taking the time to explain and go through everything. I agree, and like Dr. Kapnick has said, I have a bit of experience. I work at Imperial in London. I'm a clinical research fellow, so I'm doing my PhD in thermal imaging and looking to recruit patients from that perspective, sort of aspect of things with thermal imaging. I guess my question to you from your work or what you've done so far, especially with the compliance, is whether you've done any comparisons between, prior to them having the thermal image explained to them and before that, if there's any sort of behavioral stuff that's been done. Because myself, and actually I was discussing with David Wright sort of last year or so, the aspect of potentially being able to compare patients' perspectives or views in sort of a survey or like some type of assessment before and after showing them a thermal image and how that would go about. Because I think that element of things has been very untouched, but is quite an interesting and new aspect to thermal imaging, if that makes sense.
Oh yes, that's a very interesting point. So we are embarking upon a study to try to determine patients' understanding. We're still in the process of figuring out what the protocol is going to involve, but trying to figure out how much patients understand after DUS, showing them a ultrasound image and explaining it to them, as opposed to showing them the thermal imaging and explaining that to them, and try to determine which patients have better understanding. Or is it going to make sense, of course, doing a combination, which I think is what's going to be the ideal thing. But I'll tell you from practice, and we started this, we introduced thermal imaging in July last year. Lowell and I have been working together with getting several studies off the ground. What we found, quite interestingly, is that patients' compliance, now this is unpublished data, patients' compliance has increased significantly since the introduction of thermal imaging and explaining the thermal image to the patient. But we have to find a way of measuring that and proving it.
Yeah, very interesting, definitely. I think for some of the recruitment that we've been doing, because we approach patients in clinics as well, we've been doing a thing where we show them the ultrasound and then we also show them the thermal image and just ask about what their preferences or what seems a bit clearer, because a lot of it, as you've shown in your imaging, is that it's not a sort of, degree temperature, but rather the visual changes you see on the image, and that's like an instantaneous thing that helps with patient education. So I definitely think it helps with compliance or just general patient understanding, because when you explain things about venous insufficiency in a bit more detail, you sort of, sometimes face a bit of difficulty in patients understanding exactly what that means and why they benefit from treatment. So I definitely think that's very interesting. Dr. Wright?
Thank you, Dr. Sally. There's a question from Anil Hingorani about the cost of the technology. Did you hear me, Dale?
Sorry?
There's a question in the chat box from Dr. Anil Hingorani about the cost of the equipment.
Oh, hi, Anil. So from what I gather, the actual FDA-approved piece of equipment cost, the camera itself, would cost in the region of about 5,000 US, if I'm not mistaken. And there is meant to be an annual fee for upgrading and cloud storage and the use of AI. But Anil, I can't get the details to you and have one of the reps reach out to you to give you the exact costing.
We can post it on VLU as well, so
Okay.
that would be helpful. David, comments, questions, and then I have a few.
Yeah, I think obviously that worked out very nicely, and you covered the whole area very, very well. I think there are just a few little things that are important that I would like to say about this, is that the actual camera is literally picking up heat, and it warms the chip inside the camera, and so it takes a little bit of time. So the pictures aren't instantaneous, but it's sub 1 second. So it's not a burden, but you just have to understand it. You've got to keep the camera relatively still. The other thing is that equally, the whole process is a physiological process. We've got reflux coming mostly, obviously, typically out of the great venous vein, and it's then running under the influence of gravity down through the superficial veins. And so it's providing this heat source underneath the skin. Obviously, if somebody's lying down, that reflux isn't there. And so when you stand them up, it's going to take a few seconds, maybe half a minute to 2 minutes, to allow the skin to warm up to transmit that message. So there are some little tricks of the trade that you need to be aware of, but essentially it's a super rapid process. It's not particularly environmentally dependent. We seem to auto-regulate our skin, and right across a whole array of people and different countries, the superficial skin temperature of the leg is around 30 degrees Celsius. Obviously, core temperature is 37, and as you illustrated in the diagram, that warm blood is then escaping from the deep out to the superficial, the fundamentals of varicose vein disease, and heating the skin over it. So there are some little timing issues, but in general, it's very straightforward.
Thank you, David. So one of my questions here, I know that together they're better than the individual parts, but as we go forward in trying to reduce the inaccuracy of sometimes duplex ultrasound or potentially looking at the spectral analysis and trying to figure that out. It seems to me that this may be helpful in having two of the modalities be consistent. What is your opinion, Dale, Dr. Sally, and Dr. Wright?
I let Dale go first. You'd like?
Sure, doesn't matter.
So actually, Lowell, you could run that question by very quickly again. Sorry.
So the question is, we have issues sometimes in the United States, and else places have been reported that the spectral analysis can be difficult sometimes to interpret, sometimes can be adjusted to make it look like reflux. And the question now is, or the statement, the additive properties of both thermography and duplex ultrasound to be consistent may be helpful to be more realistic than the individual parts. So the
Okay.
modalities together are better than the individuals.
Oh, definitely. So I don't want to get into discussing each one by itself, and if you had a choice, which one would you go with?
Didn't ask that
Because
question.
thermography is definitely an adjunctive tool when you're doing ultrasonography. So I will never now perform an ultrasound myself unless I have a thermogram. Maybe I've been spoiled that way now, and this is within the last year. But it just increases my accuracy so much more, especially for irregular or unusual patterns of venous disease, especially the lateral aspect of the leg, which I don't think most ultrasonographers, remember, not all of us are Jan Slobes or Nikos, would tend to look at the lateral aspect of the leg, but now I do because I've learned so much from the thermal imaging and how common lateral varicose veins are, including that lateral perforator in the upper thigh.
Well, let me be a little bit clearer and pose this question to you. If you see the hot spots on the great saphenous vein in thermography, and you do not see reflux in the great saphenous vein, which one's correct?
So I've never seen that. In other words, once there's a hot spot and it's not physiologic, it's a varicose vein. There is reflux there for sure.
So let me pose it the other way.
Okay.
So you don't see anything on thermography, and duplex ultrasound shows you reflux.
Good.
Okay,
Sorry,
David,
did
Can
you
I
want to
take
take
that?
any of you can jump in here.
Yeah,
This is
please.
a free for all.
I mean, there are, as Dale mentioned in the presentation, there are clear limitations. The thermal imaging is telling you about the skin temperature, pure and simple. If there's a good insulator between a hot source, i.e. the refluxing vein, and the skin, you won't see a thermal image. So
What would that insulator be?
subcutaneous tissue and
Tissue.
fascia.
Yeah, but didn't Dale mention that you could see this in heavy patients as well?
Yes, because but again, only the vessels that come up to the surface.
Okay.
And if you can imagine the GSV in its fascial sheath with other deep structures beside it, muscle, etc., that means those two adjacent structures are also at 37 degrees. Therefore, it doesn't transmit a difference to the skin. But the other point that you were trying to ask about, the amount of reflux is physiological, and is actually transmitting heat energy just by mechanically moving the heat energy around. So if you have very low amounts of reflux, you probably won't see much of a thermal change. And so I think within the thermal image, there's almost a clinical guard that you have to have sufficient speed and volume of refluxing blood to get a strong signal.
I'd also just like to add as well, kind of following on from that, but there haven't been very many studies that look into other comorbidities that could influence. I know we're talking about sort of temperature hotspots, but the element of, you know, heart failure, so large lymphedema or just general edema in the legs that could also be playing a role in what you read in a temperature from a thermal image in comparison to a duplex ultrasound scan. And ultimately, for patients who have reflux and GSVs or something that requires RFA or some type of intervention, when they're on the table and you're scanning as you're injecting, you would need them to have like a positive ultrasound scan. So as in something for that surgeon to potentially be injecting into and to identify. So I feel like I'd probably say that, as you've said, individually, they're not the best. And so there kind of would be something that would need to be done as an adjunct and as a kind of pair more than anything, really.
Thank you. Dr. Marianne de Messina has a question. Does the surrounding temperature in the room influence the result? That's one. And then for me, if you have a patient that's exercising and then comes for a scan, thermography scan, will that alter your results? So what do we have to be realistic in terms of thermography and the environment?
I'd thought I'd referred to that really a little earlier. It seems to be extremely tolerant. I've deliberately gone outdoors in Florida when it's 40 degrees Celsius out there, and it works just fine because people sweat, they're losing heat from their skin, and they, as I say, they auto-regulate down to about 30 degrees. And so the physiological impact of refluxing blood to heat the skin over that area still remains. It doesn't seem to be a problem. Obviously, you can go the other way and have a very cold environment where you might actually influence the reflux itself because all the vessels shrink down and the patient's shivering. But it's not a failure of the thermography. That's actually influencing the venous disease itself. And the other one was exercising. I don't have any particular knowledge about of that. The only aspect I would comment on is that if you are hot in a hot environment, and in particular if you wear sneakers which are highly insulating, what you will see is that you'll be able to see the bottom end of the great saphenous vein filling up with warmer blood. But it's a very obvious sign in that it's hot down by the malleolus, and the signal fades away as it progresses up the GSV tract.
And also just to add on to that really quickly as well, when we were doing our protocol for optimization of recruitment of patients, we did do comparisons of different times of the day because of temperature. So very early in the morning at 7 a.m. And then we did pictures at 12 o'clock and then again at 5 o'clock. And we actually saw that there was no difference despite sort of moving around. So we also did a 10-minute walk around the department, then took a photo and couldn't see any massive changes in temperature. So the thermal images looked very, very similar and had similar temperature readings at those hotspots. So I don't, like David Wright is sort of saying, there is this element of being able to regulate yourself quite well when it comes to taking a thermal camera picture.
So I'd like to thank Dr. Maharaj, Dr. Wright, and Dr. Sally for this enlightening conversation and bringing some new technology to the forefront. And next week, we're going to be talking about endovenous humescent delivery system. It's a new device. Could it be a game changer? We'll see you next week. Thank you.
Thank you, Lowell.
Thank you.